If you. Tá sem som aí. Não admite ninguém ainda, tá?
Boa, agora foi. Calma aí.
Eu também tô.
Então, eu tinha te colocado como... Não tá pra... Aqui como co-host. Calma aí que eu vou tentar descobrir como é que faz, né? Deixa eu adicionar o Dr. Jacques aqui.
Quem?
Dr. Jacques.
Já tá aí já. Viu? Esses que estão entrando, eles têm que ficar como host, tá?
Sim, é o que eu tô tentando descobrir como é que faz aqui. Calma aí.
O Dr. Jacques Morcos, deixa ele como co-host.
Uhum.
E aí, Torramina, Dr. Paulo, esses todos você põe como co-host.
Quem
E
que é
aí,
esse
quando for.
Dr. Faust aqui?
Não sei, pode deixar entrar já. Vamos entrando já, todo mundo.
Calma aí.
Calma que eu já vim aí, tá?
Beleza. Good evening, Dr. Morks. Just 1 minute, I'm allowing you to speak. I'm putting you at host here. Don't, Dr. Morks. You can unmute yourself.
Can you hear me?
Yes, loud and clear.
Okay, great. But I cannot, I guess you'll open the video later. The video
Opening
doesn't
now.
let me.
Try now.
Yeah, that's gonna work. Very good. Okay,
Perfect.
You see me, yeah?
I'll see you.
Let's
I
see.
allow you to share your screen too.
Okay. Are we starting in a few minutes, you think?
Yes, Dr. Andre is already here. He just made a quick stop.
They're finishing the previous presentation?
No, actually, we haven't started yet.
Oh, I thought Dr. Shekhar was speaking at 5 o'clock. No?
He is, but his lesson didn't begin yet.
I'm sorry?
Dr. Marcos.
Hey, how are you?
Hi, Professor. How are you going?
I'm doing
nice
good.
to see you again. Really happy to see you again, Professor.
We do, my friend. We need to start traveling again.
Yeah, quite sure. We need to go to Foz do Iguaçu again.
I love
to Macuco travel. Yeah.
I love this place. Oh, that's better lighting this way, isn't it? Yeah.
Oh, yeah, that's really nice. Yeah, I was looking the last 2 weeks. I was looking for the pictures that we have taken there.
Yeah.
Oh my goodness, it was completely
Amazing place.
nice. Yeah.
Amazing place.
We are planning to do another congress maybe next year. So then we're gonna ask you to come here again. So it'll be a pleasure for us. So we are planning to do maybe in São Paulo or in Curitiba, but we are not sure yet. We are planning to do it by the academy.
Yeah.
We are changing now the president, so next year going to be another president, Dr. Dezena.
Uh-huh.
Then we are planning another congress because this year was really horrible because of the pandemic. So we wanted to travel again so much.
No, understood. Hold on, I'm looking for my phone. Okay, give me 1 second. Is Shaker? Oh, sorry. What's that?
Maybe I thought that Dr. Shaker was going to be here, but he asked me to begin in 1 hour since now. So because he's in surgery yet.
Oh, so I thought I'm after him. Okay.
Yeah. Should be after, but he's still in the surgery. So we're going to start with you, Professor. Then Dr. Shaker, going to be the following.
Okay. So you want me to speak for about 1 hour, or what? What shall
1
I
hour?
do?
I think 1 hour is perfect, Professor. It's I think it's enough. But if you want to speak a little bit more.
No, it's okay. Actually, no. If he's coming, and anyway, thank you. I have to go somewhere too. So okay. 1 hour is great. Are you recording, or where are
we're
there?
Going to record it. Yes, that's right. We're going to record because we are in I think about 100 neurosurgeons from the whole country, but we're gonna share this video again, maybe for more 100 or more 200 neurosurgeons during the week. So some of them are not able to be tonight here, so we want to share this video.
There are some that are live tonight, I guess.
Yeah, that's right. Yeah.
Okay. All right. Perfect.
For this course, we have more than 300 neurosurgeons. Wonderful. So, yeah, all from the Brazilian Academy, and I think Dr. Flavio is coming, Dr. Dezena is coming as well, and Dr. Ramina is coming in a few minutes.
I'm ready whenever you want.
Okay, I'll ask Dr. Ramina to come right now, and then after he comes in, we can begin.
Okay.
I have right here something about you, so have something to read about you, but so many words, so I wanna resume. Otherwise, I'll be here for a whole day speaking about you. So
oh, we don't want that. We don't want that. The less you say, the better.
Yeah, no. Dr. Ramina is here, I think.
Hi,
Dr.
Jack.
Ramina.
Ricardo.
Nice to see you.
Good to see you, my friend.
Thank you. The same. How are you doing?
I'm doing great. I was in Lebanon recently, and I just came back from Montana. We had the SUN, Society of University Neurosurgeons, in Montana. It's a beautiful part of the country that I didn't know. I did whitewater rafting. I had to have bear spray because there are grizzly bears there when you go for hikes. So
that's very nice. That's good that you can go again to Congress, because we had this big problem until now, but now I think it's better.
Well,
I was last week in Switzerland for 1 week holidays. It's very nice to stay there for 1 week and forget everything.
You're right. You're right. Yeah, it's too bad AANS had to cancel. It was going to be next week. But Florida is not doing well with COVID.
We will see. In Brazil, we have all the same problem here, but we hope it will be better in the next month.
I hope so. But you know, even Israel, that is the most vaccinated country, is having trouble right now with the Delta. I mean, it's really bad. I don't know if we're going to get out of this unless we vaccinate everybody. The US is just about 50% vaccinated. It should be a lot higher than that.
Yeah, that's interesting. That's a different disease because we don't know what is going on.
Right.
Even in China, we don't know what the Chinese people are doing because if you look at the statistics, they are doing very well, but the reality is probably different.
Yeah, you're right. You're right. There we go.
Okay, Andre, I think we should start because it's 7.
Yeah. I think so. Yeah, we're still waiting for some neurosurgeons to come in. I'm going to ask them to come and join us here at Dr. Marcus' lecture. Just 1 more minute, Dr. Amina.
Hi, Paulo. How are you doing? It's Paulo Henrique to us. How are you doing, Paulo?
Pode soltar ele, João. Solta ele como...
Já tá solto até.
Okay. Dr. Paulo, are you here? Can you hear us?
No, I can hear you.
Okay. Nice.
Jacques, how is the situation in Lebanon?
It's not terrible. The COVID situation is not terrible. Everything else is horrible. I was just visiting my mother. It's horrible. Corruption. The US, the Lebanese pound has devalued 90%. When a doctor, my friends who are doctors there, when they see a patient, do you know how much they charge? They charge $10 for a consultation. I mean, it's nothing. If the doctors are, you can imagine how much poverty there. It's terrible. It's the worst ever.
That's terrible because Beirut was one of the most beautiful cities in the world.
Yeah. Absolutely. I don't know how they're going to get out of it. And all these articles that are being written here in the US about Lebanon, it's really depressing. It's corruption, you know, greed, corruption, political people doing things for their own. These politicians, they should all be lined up and shot. I tell you, the way they suck the money out of people, it's unbelievable.
That's a big problem. We have the same problem in Brazil. Brazil is a large country, very rich country, but you have always terrible politicians here that are not doing anything for the country.
Right.
That's terrible. That's a huge country. We have everything you need here, but you have this politician. It's terrible.
Yeah.
We imported a little bit the corruption of the world.
How are you, Paulo? Good to see you, my friend. I'm glad everybody's healthy.
Fine, thank you. I am here, sorry, without the tie or because
I have a tie. I'm even worse. I'm in my scrubs.
But you are with scrubs. I am here. It's a pleasure to have you here. I am in hospital. I am with COVID now.
You have COVID?
Now, just now, but I am very okay. I am better. Hamina phoned me yesterday. I was more or less. Today I am much better with 96 of saturation. And we say in Brazil, bad things are difficult to die. Then I am here alive.
Well, you know, go and rest instead of listening to my lecture. You should go and rest. What you have to do this.
Yes, it's a pleasure to have you here.
Oh, I'm glad you're well. I mean, I'm glad you're better.
Yes, I am very bad.
Were you
Better.
vaccinated?
I am much
Are you
better than yesterday, and Brazil now is decreasing the number of COVID, but we have the Delta variants.
Yeah.
But I am sure that in few months that it will be stopped in this country because the vaccination is everywhere and the people are taking care and avoiding crowding and so on. Um, Returning to our symposium, it's a pleasure to have you here. It's an important symposium that Professor Hamina is our icon, our leader in Brazil, and André Giacomelli, the future of this country, that have organized it. And I could not be here today, even if I were worse, I would be here because it's important to stay and listen to so nice symposium organized by them. Thank you, Ricardo. Thank you, André. Congratulations for this wonderful organization. And thank you, Marcus, to be here in Friday night in Miami, very hot Friday night.
That's
But I
right.
know it's worth a while to be here and listen to your lecture and learn. We have young people here that should know how to proceed. Thank you very much.
Thank you.
Thank you, Professor Paulo. So I think we are able to start right now. We have our.
Sorry to interrupt you. I don't see anybody anymore. Do you see me? I don't see you. All disappeared. Do you see me?
Yes, I'm seeing you very well.
Oh, I
Yes.
lost all your faces. You're all gone. I only have my slide in front of me. Is that how it's supposed to be?
It's our kind of Zoom that we are using.
Okay.
So we can
That's
share
fine.
for
That's
everyone.
fine. As long as you see me and you see my slides, that's okay.
That's
Dr.
perfect.
Jacques,
Yes.
I think you're going to share your screen again.
Oh,
Your slides closed first.
We cannot see your slides, Professor.
Yes.
If you can share again. Okay, now
Now
you
we can see it.
yeah. Now I see you. Okay.
Perfect.
Perfect. So it's very nice to be here with us again for the sixth module of this course. That is one of the best neurovascular courses in this year in Brazil. Very grateful to the Academy, so the Brazilian Academy of Neurosurgery, and Dr. Amina and Dr. Paulo as well, that are the organizing committee of this course. So now we're going to start with Professor Jacques Marcus, and afterwards we're going to have Dr. Sheikha. He's in surgery by this moment, so in 1 hour and a half, he'll be here with us as well. So let's start with Dr. Jacques Marcus. So he's a very well-known professor. He's a professor and chairman of the Department of Neurological Surgery at the University of Miami, as well as the director of school-based endoscopic surgery and cerebrovascular surgery at the University of Miami. Dr. Marcus' training began in London in the National Hospital of Neurology and Neurosurgery at Queen's Square in Maida Valley in London, England. He completed his residency at the University of Minnesota and his fellowship at the University of Florida and the Premier Barrow Neurological Institute. He has received numerous awards from the Royal College of Surgeons of Edinburgh, the American Board of Neurological Surgery, and is currently the director of the North American Skull-Based Society. Tonight, he's going to present us with a lecture about something that he's super expert, that is about bypass surgery for aneurysms and ischemia. Doctor, the time is yours, so you can be our guest now. Thank you very much again.
Thank you again. It's a pleasure and a privilege to be invited by the Academy, by Ricardo, by you, Andre, by Paulo. Always pleasure to be with my Brazilian brothers and sisters and colleagues. And so I will, so for about an hour or so that you gave me, I am going to try to cover bypass for moya-moya and steno-occlusive disease, as well as aneurysms. It is a lot of material, and I'll make sure I won't really go beyond 1 hour. But I did have some new things I want to discuss in moya-moya and steno-occlusive disease. So let's hope I leave myself enough time to discuss bypass for aneurysms as well. My disclosures are completely irrelevant to this talk. This work, part of this work is in a manuscript, 2 manuscripts. One has been accepted and is in press in JNS, and one has been prepared and is being considered. And of course, I thank all my team of stroke neurologists and residents and fellow, my former fellow, Nick Khan, in cerebrovascular and skull-base surgery for helping put most of the data that you will see together. I was interested in looking at my experience with bypass for moya-moya and steno-occlusive disease. I looked at about 21 years. I was the only surgeon in that series. There are 3 types of direct bypass that I performed over these years, what I call 1 donor, 1 recipient, that's 1D, 1R, 1 donor, 2 recipients, or 2 donor, 2 recipient, meaning double barrel. This is a typical craniotomy for a bypass. Let's start with a case example of this 32-year-old female who is a nurse who presented with a stroke, and she has an infarct. And here is a typical angiogram for moya-moya disease. You can see the narrowing of the distal ICA on one side. You can see the attempt at collateral formation from the posterior circulation. You can see the small STA in the external injection. Here in Miami, we like to do transcranial Doppler with vasomotor reactivity studies. You can see these are very low in her, 27% in the right hemisphere, 32% in the left hemisphere. We used to do SPECT with Diamox. Nowadays, we do CT perfusion or MR perfusion. And I proceeded with the direct bypass surgery. By the way, I exclusively do direct bypass. I do not use indirect bypass in my practice. You'll see a little later what the results are, but it's almost always possible, unless it's young children, to do direct bypass surgery. So this is how back then we did this patient. You can see the tracing of the STA, the isolation of the STA branches, the small craniotomy over the distal sylvian fissure, 6 centimeters above the external auditory canal. That's the center of the craniotomy. That usually gets you to the distal sylvian fissure. I like to use the Charbel transonic flow probe to measure in cerebrovascular surgery the blood flow. Here I am measuring the recipient M4 artery, 3.1 cc per minute. I then cut the STA, measure what's called the cut flow, and that's 60 cc per minute in this case. Then I proceed with 1 anastomosis. In this case, I use running suture, and there is a donor STA. Then I measure the bypass flow. Look at the number, 64 cc per minute. It's more than the cut flow. So it's more than 100%, the so-called cut flow index. Again, a concept by my good friend Fadi Charbel. CFI is bypass flow divided by cut flow. So it means the brain has sucked all the blood that you give it. And here we are measuring the flow in different directions in the recipient, antegrade and retrograde. And here is the post-op CTA. And you can see it. It's a very nice patent bypass. And here she is doing well after one side. And then a few weeks later, I did the other side prophylactically. And you can see the angiogram after doing the other side. You can see right side patent bypass and left side patent bypass. So that's your ideal case in Moya Moya. How about steno-occlusive disease? It's more controversial. I don't have time to go over the COS study and what it said and how they said that bypass surgery should not be done for cerebral ischemia. But the problem with that is we have all seen patients who benefit from it. So this is a typical case. He was 76 years old at the time. You can see the watershed ischemia in the right hemisphere. He has cervical carotid occlusion. You can see here the angiogram. And this poor man was having TIAs every day. And he did not have good collaterals. That's why he was having TIAs. You can see the left carotid does not cross over via the ACOM. And here is a SPECT with Diamox showing paradoxical hypoperfusion in the right hemisphere with Diamox. It means there is a steal of blood flow from the right to the left hemisphere. So this is clearly type 2 ischemia. Here is the VMR. Very poor vasomotor reactivity by transcranial Doppler is very poor, is 19% in that hemisphere compared to 55% in the other hemisphere. So I did his bypass, single 1D, 1R, one donor, in this case, one recipient. Here is a patent bypass. This man lived for 10 years and died of a heart attack 10 years later without having any more strokes or TIAs. So clearly, it does help. So what I've done in my study, I have analyzed all of these factors that you would think we would analyze. Degree of severity of disease, suitability of donor, degree of collateralization. Is the collateralization compensated or not? We looked at the 3 types of collaterals you can get: transdural or leptomeningeal or cross-flow, a cross-flow via the ACOM or the PCOM. Those are the types of collaterals you can have. We also looked one more thing deeper. We said, well, how much of the hypoperfusion is uncompensated, meaning when you overlap all the angiogram injections, is there an area that still does not get enough blood flow, at least angiographically? So here is such an example. So this is uncompensated area of hypoperfusion. So we did that on all the patients that we could get review the angiograms on. We looked at Matsushima grading, A, B, or C. We looked at bypass patency. Here is a typical bypass that has matured over time. You can see how much bigger the STA gets over time, several years after the bypass. And here is another example. 11 years after the bypass, you can see a very nice STA in the bottom 2 images of the 3D. Here is an example of an acute bypass occlusion 2 days after surgery. You can see on the left, and I took the patient straight back to surgery and revised it urgently. There was a technical problem with the recipient artery. Here is a typical example of a delayed bypass occlusion, meaning a bypass that was patent at first. You can see that, and then gradually over time, the bypass shrunk away and indirect collaterals came in, and they are the cause of why the direct bypass disappeared. The patient remained asymptomatic. So I looked at the TCD VMRs in the patients. We've done that. And again, a normal value should be more than 70%. We also, in the times of COVID, we did the breath holding index because with COVID, it was difficult sometimes to get the TCD VMR. It requires different equipment. We looked at angiograms, and here are the results. I have 162 procedures. Some patients were done bilaterally. My clinical follow-up is almost 3 years. My range 1 day to 21 years. My angiographic follow-up is 1 year and 9 months, with 1 day to 12, almost 13 years in the maximum follow-up. And of course, over time, my referral basis increased. So my first 7 years, I did 14 surgeries. The next 7 years, I did 41. And the last 7 years, I did 107. So here are the results. 162 hemispheres. I am not going to bore you with the demographics, but you can see the 3 different categories: Moyamoya disease, Moyamoya syndrome, or steno-occlusive atherosclerotic disease. So I separated them in those 3 groups, and then the overall patients. Again, too much information that's not too useful really to go in detail over, but to show you that I looked at everything: comorbidities, modified Rankin score, pre-op. I did Suzuki grade, I did collateralization, what vessel was affected, the degree of stenosis, the post-op Matsushima grade, and post-op patency. Even in successful cases, don't expect the transcranial Doppler VMR to improve, to get normal. It never gets normal. For example, here, the average pre-op VMR was 29%, and post-op VMR 39%. It improved, but it never reaches the normal range. So don't be discouraged by that. Those patients, as you will see, are doing very well in spite of a VMR that is not normal post-op. Same thing with SPECT. Now, I analyze blood flow in every case, and that's what I'm going to analyze next. But before we do that, let's talk about surgical morbidity. So there is 10% of what can be considered surgical morbidity. But let's analyze what those are. Ischemic stroke is only 0.6%. Intracerebral hemorrhage, 3.1%, from the procedure within 30 days. Subdural hematoma, 1.9%, wound complication, 1.3%, respiratory failure, 1.9%, and myocardial infarction, 1.3%. When you add all this, you come up with 10%. But if you look at ischemic stroke and intracerebral hemorrhage together, that's 3.7%, interestingly, quite a bit better than what was reported in the COS study, which was about 15% perioperative. These are the 6 cases in detail of surgical morbidity that had a hemorrhage or a stroke. I don't think we need to go over each one of them in detail. These are the first 3: hemorrhage, stroke, hemorrhage, 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 hemorrhage. And again, each case had its own reasons and so forth. Here is a very important finding that has not been described before. If the patient have complete collateralization pre-op, their chances of occluding their bypass later on in a delayed fashion is 36%. It doesn't mean they are symptomatic. It just means that the direct bypass can occlude much more commonly than when they have incomplete collateralization pre-op. If they have incomplete collateralization pre-op, the chances of delayed bypass occlusion is only 4%. So look at the difference, 36% versus 4%. It shows you that each patient is different, and the impetus to grow indirect collateral, whether it's due to VEGF or other factors, is different between patients. Here is an exact replica of what I told you in graphic format. On the left is the occluded bypasses, on the right are the patent bypasses, and in orange is the patients who had incomplete collateral pre-op. In blue had complete collateral. You see, big difference between the two groups. What are the clinical outcomes? Orange is post-op modified Rankin score. In blue is pre-op. You can see the patients did better. They moved more to the 0 and 1 MRS score after surgery. So I'm clearly helping patients. I'm clearly selecting patients for the most part appropriately. Here's an interesting comparison. When you compare one donor, one recipient versus versus one donor, two recipient versus two donor, two recipient, there isn't statistical difference, but you can see the trend for improved flow. The more anastomoses you do, improved cut flow index with more anastomosis you do. I am going to detail this a little later in the talk. So we did univariate and multivariate analysis to see what correlates with delayed bypass occlusion. There were only two factors. One of them I don't have a good explanation for. Hispanic race. I live in Miami. Many of my patients are Hispanic. We could not sort out why that is. But the other much more clearly relevant and logical factor we found is the presence or absence of, as I said, preoperative collateralization. So those are the only two factors. Interestingly, the cut flow index, which was described by Charbel et al. To correlate with delayed bypass occlusion, did not in my series correlate. I'll come back to that in a second. Let's show you some video examples of 1D, 2R, meaning a single donor, and you do side-to-side anastomosis and end-to-side anastomosis with the same branch of the STA. Why would you do that? You can see this is a Moya case. You would do that to prevent, to avoid dissecting the anterior branch of the STA, to minimize ischemia to the skin, to make the surgery faster, simpler. But of course, I don't think you should do this 1D, 2R technique unless you have some experience with bypass surgery, because if you have a technical problem with the donor, you will lose both anastomoses, and that can be a problem. Here we are injecting a Glow 800, that's ICG, to visualize the STA. When I cut it, it had a flow of 50 cc per minute. And then we are going to do the craniotomy. I do it different ways. The muscle, you can cut it in a T, or you can turn it in a C shape. Then we are going to bring the STA. We have two recipients, one on the temporal and one on the frontal. I isolate both, one on each side of the Sylvian fissure. I measure flow as I do. You can see what the flow, they're low as expected before the bypass. And then we are injecting ICG, and we are going to mark and a 10-0 suture. In this case, I'm doing the end-to-side bypass first. We are going the temporary trapping of the recipient. It's a typical anastomosis. I like to do a very sharp arteriotomy. I fish mouth the donor STA. I always start at the 12 o'clock position. Sometimes I do interrupted, sometimes I do running technique. And here we are doing interrupted and going around and releasing the clips. You always want to see a little bit of bleeding. If you see no bleeding whatsoever, it could be occluded. So don't celebrate if you see no bleeding. So a little oozing is normal until the platelets work. Now, notice the number, 43 cc per minute. You will see how it will change when I do the next anastomosis, which is this one, side to side to the frontal M4. So now you stop the flow temporarily and you do this, same thing, but now it is a side to side, same principle. You do the, in this case, I'm running the back wall, and you do the back wall first, of course, otherwise you cannot access it if you do the front wall first. You run it endoluminally, and then you do the front wall. Then you release everything, and now you measure the flow. And remember, it was 43 cc after the first anastomosis. When all the clips are removed, we now have 2 anastomoses, single donor, 1D2R. Look, it increased to 60 cc per minute because we opened a new hole in the donor artery. So, and then I measure which part, how much goes to each temporal lobe, how much goes to the frontal lobe, 22 and 38. That was, in this case, the division. Here is a summary of the final numbers, very important in making you understand what you're doing on every case, in addition to ICG. And here we are putting the bone flap at the end. And here is a post-op angiogram. Both anastomoses, you can see, are patent, and there's an excellent perfusion. And the patient did great. I am going to skip a 2D2R example. It's a double barrel. It's the same thing, but you're using anterior branch and the posterior branch, 2 separate anastomoses here. But to show you that, of course, to look for the anterior branch, you have to lift the scalp and look from the inside and isolate the anterior branch. That's how we've always done double barrel. It's a little more tedious. There is a risk of necrosing the scalp, but certainly is another well-known technique. I am going to skip this video. It's nothing really new as a concept, same thing, measuring flow. Now, remember the posterior circulation, you can also have vertebrobasilar insufficiency. So sometimes you have to use occipital artery to pica bypass. I'm going to show you quickly such an example. Look at this case. The vertebrobasilar system is very poorly perfused. And here it is in 3D CTA. And the patient was symptomatic with posterior circulation symptoms. So here is the occipital artery. This is my planned craniotomy, a far lateral approach. Here is the position at surgery. I insonate the occipital artery, and I skeletonize the occipital artery. And here is after doing the craniotomy, I will find the pica, the telovelar segment, the tonsillar segment of the pica. You will see it right here. We will put a retractor on the tonsil to lift it up. Here are the lower cranial nerves and hypoglossal nerve. There is a lot of room in a far lateral approach. We put the retractor. Here is the 4th ventricle. And then you need to make sure you don't trap a perforator of the pica. So here I've isolated a segment of the pica. I'm using this loop to measure the length of occipital artery I need. Then I cut the occipital artery and I anastomose it to the pica, end to side to the pica. You can see it here. Yes, it is of course deeper than an STA MCA, but there is plenty of room and it's not particularly difficult. Make sure you don't trap or injure pica perforators. Here we are doing the arteriotomy. Otherwise, I like to use always a curved needle holder, 10-0 suture, because you need to be able to manipulate with your wrist at the depth. And I'm not going to show you the entire anastomosis. When you finish, you release the clips. And if there is a leak, you fix it with another suture or a little Surgicel. And here is the anastomosis completed and a good flow from the occipital to the pica, measuring the flow and closing everything at the end. Here we are, dura is approximated. And here is a post-op angiogram. You can see the occipital to pica. A bonnet bypass is a very rare bypass. I put the saphenous vein from one STA to the other MCA because the common carotid artery was occluded. I don't, again, just for the sake of time, I don't want to show you the entire video, but just to show you what it might look like. Here is a saphenous vein being anastomosed to the bifurcation of the STA. And here is, we have to drill a channel in the bone so that the skin of the scalp does not occlude the vein, because it's a big vein under the scalp. So after doing that, you see it's going to look something like this. And you can see the trough in the bone, and I put some plates to hold the saphenous vein. And then I split the sylvian fissure on the other side, found an M3, and I did the anastomosis there. I'm going to skip all that just to show you really the concept. So just to show you that in my series of 162 cases, we had very good results, low morbidity, mortality. Compare this to the costs. I only was unable to perform a direct bypass in one case out of the 162. In that case, the recipient was very poor. I did an indirect bypass. Intraoperative flow measurement show a median of CFI of 0.86 and a final median bypass flow of 52 cc per minute. But please notice the range. There is one patient who had 198 cc per minute with an STA-MCA bypass. So again, I echo what Charbel has always talked about, is that you cannot call STA-MCA as a low flow bypass. You don't know what the flow is unless you measure it. So don't use the expression low flow bypass because simply it's an STA-MCA. It can be anything. Now, here is the series of Charbel in the left column. In 2019, they had 146 cases. I was puzzled because in my series of 161 case that I'm showing you, the CFI, cut flow index, did not correlate with long-term patency. And in their series, it did. And I was curious why. And the only explanation I can postulate is that they used indirect bypass concomitantly on the same patient with direct bypasses in in more than a third of their cases. So perhaps because they added muscle and dura on their bypass, the direct bypasses involuted as the indirect collaterals formed. That's the only thing that is a major difference between our two series. The other difference is that I use 1D2R more frequently than they did. And that's why perhaps the patency rate in my series is 91% versus 76% in their series. And you can see at the bottom why CFI did not correlate in my series with long-term patency, but it did in their series. So these are my possible explanations why there could be discrepancy between the two series. So again, in summary, the stroke and ICH morbidity after direct bypass in my series was 3.7% at 30 days. And overall follow-up after surgery, 6.2%, which is a lot better than the natural history of moya and cerebro and steno-occlusive disease. Mortality, one case only, which was actually an anesthetic complication of hypertension intraoperatively. I will skip that. So I want to introduce a new concept by analyzing the sub-series of 1D2R. I'm going to go quickly over this to have some time to talk to you about aneurysms. So 1D2R, I showed you that first video. So I have 21 cases, which actually, as far as I know, is the largest series of 1D2R in the literature. The first person to describe it is actually Charbel in 2018. They had 7 cases in that 2018 publication. At this time, I have about 30 cases, but this is in press and will be published in 2 weeks in JNS. So I invite you to look at the details because I won't have time to share with you the details of that series, but I've learned a lot by analyzing. Let me go quickly. You need to understand some math, a little bit basic Pythagorean geometry. You need to understand a little bit Bernoulli equation. You need to understand, more importantly, the Hagen-Poiseuille law, which is the equivalent of Ohm's law in electricity. This is Ohm's law on the right, Poiseuille's law on the left. It talks about resistance, perfusion pressure, and flow. These 3 entities, how they are linked together. Again, it's not really the time to go into details, but please read the paper and you will know exactly, you'll understand more of the details. If you don't mind, I am going to skip through many slides that get into bypass, what keeps bypasses patent. This is basic hemodynamics we've all learned from cardiac surgery and the coronary bypass and so forth. These are the geometries of bypasses. And when you do an end-to-side, the reason you fish mouth the donor is so you can quadruple, 4 times more cross-sectional area in the column on your right compared to if you don't fish mouth the donor. Basic Pythagorean theorem. When you do the end-to-end, you try to make it an oblique cut so you get more cross-sectional area, and this is a side-to-side. When I do a side-to-side, I like to do my arteriotomy at what I call 130 and 1030, between best apposition and best visualization, when you put the 2 vessels side by side. So again, I thank my residents and fellow for analyzing my data. These are the 3 types of collateral formation. Again, to repeat, I always use flow measurements. Here is a 1D2R, what it's going to look like when you finish. Side-to-side anastomosis on your left and end-to-side on your right. I showed you a video of that example. I'm going to skip it in this section of the talk, reminding you that it is exactly like an electric circuit in parallel and in series. I will show you in a minute what I mean. Again, I analyzed collateral formation. So 21 cases. Here are the steps of the surgery of a 1D2R. First, you place the STA on top of both recipients. You do usually the side-to-side anastomosis first. You measure the flow in that. After that first anastomosis, you measure the CFI after the first anastomosis. Then step number 3, you do the end-to-side anastomosis next. You measure the flow in the first anastomosis and in the second anastomosis. And now you can obtain 2 CFI based on when the anastomosis is done. The results, I'm going to skip some demographics. Here are the results. Bypass patency was 100% immediately, but 90% on delayed follow-up. But notice the CFI after the first anastomosis was 0.64, it went up to 0.94. So again, you're giving more flow with the same donor. You increase on average 50% the flow. And statistically, this is significant. So on the left is the cut flow of the STA before you use it. In the middle is after you do the first anastomosis, and on the right, it goes up again after the second anastomosis. So it shows you the benefit of doing a double anastomosis, even though it is a single donor. And here I am analyzing whether it made a difference, whether I did the side-to-side anastomosis first or the end-to-side anastomosis first. It did not make a difference. But of course, if you think about it, it makes more sense to do the side-to-side first, so that when you are doing the end-to-side next, the flow is going through the side-to-side, so you don't have to put temporary clips on it. Clinical outcomes improved in these 1D, 2R patients. Look at the orange graph. These are better modified Rankin scores post-op compared to pre-op. Again, when you read the paper, you will understand how I analyzed the electric circuit analogy. You can calculate, actually, when you look at this diagram at the bottom, you can calculate the vascular resistance of each portion of the 1D, 2R. This illustration is by Roberto Suazo, our very talented artist, and we're hoping that the journal will accept it as a journal cover. Well, we're still waiting to hear. But this whole thing is to show you the electric circuit analogy, and by using Ohm's law or Poiseuille's law, you can calculate each segment of the bypass. And here is a blow-up of the analogy with electric circuit and the formulas to calculate each segment. Again, some of the formulas to calculate the resistance. So the benefit of the anastomosis, it decreases the vascular resistance and therefore allows more flow to go in. By doing it this way, I was able to think of two new concepts, and these are new concepts I'd like to introduce to you, what I call SARA and SASI. SARA stands for second anastomosis relative augmentation. If you divide CFI final by CFI initial, that's SARA. That gives you an idea of how much more the CFI increased. SASI, SASI, is final flow of the second anastomosis divided by the final total flow, meaning what percentage of the total final flow is due to the second anastomosis. It's related to SARA, but it's in a way different. And again, when you read the paper, you will understand which vascular resistance affects SARA, which ones affect SASI. So I measured SARA and SASI on each patient, and I'll show you the results in a minute. This is a typical case of wonderful patent bypass at the end. Only one patient occluded in that series. Oops. Sorry, can you still see my slides or no? Sorry.
No.
It disappeared by itself. Hold on, excuse me 1 second. I don't know why it disappeared. Let me reconnect. Give me 1 second. Sometimes, you know, these computers, they have a brain on their own. I apologize on behalf of my laptop. Almost there. Let me see where I was. I think I was, yeah. You can see this slide, yes? You can hear me. Can you hear me?
Yes, very well.
Okay, thank you. So this is a single patient who occluded bilaterally. Here he is. The top row is the right side bypass. The bottom row is his left side bypass. Both of them, you can see, were completely patent immediately after surgery, but then gradually both of them closed off at 1 year. It shows you not that there was and by the way, the patient is doing excellent, no more symptoms. It shows you that in some patients, indirect collaterals can take over, and then the direct bypass slowly disappears. That's the only case in the series that did this. Here is a comparison between 1D2R, which is what I'm favoring nowadays, compared to 2D2R or the 1D1R. When should you not do a 1D2R? If you look at the bottom right cell, yellow, not suitable if the donor is too small in caliber or the STA bifurcation is at the level of the craniotomy. If the STA bifurcates too high at the level of the craniotomy, you might as well use a double barrel because the two branches are in your way. And as I said, it's not a good idea for the inexperienced surgeon to start with 1D2R. I think you need to have some experience so you make sure technically everything goes perfect. So in summary, the 1D2R shows an improvement because you are shortening the L, the length of the bypass in the Poiseuille equation. You are diminishing the R, the resistance. And because of that, I was able to have a very nice SERA, a mean of 1.79, and a very nice SASI of 0.4 on average in that series. And again, this is a new description of a new concept. I encourage other surgeons who do bypass surgery with double barrel, with 1D2R, to measure SERA and SASI as I am defining them. I'm curious to see what other groups will get. So my conclusion, of course, for the 1D2Rs is that it's very encouraging, the results are good, and when possible, you should use it for ischemia and moya-moya. My overall conclusion for all the moya-moya and atherosclerotic ischemia is please don't abandon bypass surgery, because as you can see, in selected patients, it transforms the life of those patients who are suffering with recurrent strokes. But I encourage you to measure blood flow intraoperatively to understand what you're doing. I haven't shown you the literature, but direct bypass surgery is vastly superior in adults to indirect bypass surgery. In young children, they are probably the same, but in adults, there is no comparison. The amount of added perfusion you give with direct bypass surgery is significant. Let me see. I'm looking at my time. It's now 6:53. Do you want me to go through aneurysms, bypass for aneurysm kind of quickly, or should I stop here? I don't know if there are any questions. You tell me what you prefer and how many more minutes to speak if you want me to speak more.
I think we can make some questions now, and then afterwards you could talk a little bit about aneurysm, bypass for aneurysm. Because
whatever you'd like.
Yes, I think it's better we discuss a little bit now.
Okay.
That's a brilliant presentation, a new concept, Jack. Very, very nice. I appreciate very much. I have some questions for you. The first is the indication for surgery. You know, when we started bypass, I was in Hanover at that time, in Toronto meeting, and we performed almost every day bypass at that time. And then we had this Toronto meeting, and the problem was on the table. And we got stopped, but we reduced our indication. And I saw you perform some bypass for not occluded arteries, but sub-occluded artery for stenosis. That's new, because at that time we performed for not occluded arteries, and then we stopped after this Toronto meeting, cause studies and all. Which case you are doing if the artery is not occluded, like the carotid or the medial cerebral artery?
Yeah, Ricardo, of course, all your points are very valid. What I am not showing you is all the cases that we are not operating on. I am only obviously showing you, this is over 20, 21 years in relatively speaking, very few numbers, like 48 or 49 atherosclerotic cases that ended up being operated, because I work closely with my stroke neurologist. These are the patients who are failing maximum medical therapy. Plavix, aspirin, and the mechanism of their symptoms is hypoperfusion, obviously not embolic. We have always two physiologic tests, whether it's CT perfusion, MR perfusion, or SPECT with Diamox on one hand, and transcranial Doppler with vasomotor reactivity. All of those things have to be, not negative, have to be poor, subnormal to justify me doing bypass. If incomplete, if it's stenotic M1 and they have normal VMR by TCD or normal perfusion by CT perfusion, I am not going to do a bypass. I can make them worse. I can create sudden occlusion of the M1 in the perforator segment and make the patient worse. I need to have all of these boxes checked, and those are the patients who end up having bypass. And I think I'm the only surgeon, but this is a group of stroke neurologists who work with us here, University of Miami. Those are very selected patients. And I think we are clearly selecting them properly, because to be honest, our results are clearly better than the COS study, not because I am I'm certainly no better technical surgeon than some of the experts in the COS group, but I think our patient selection was very good. I mean, that's the only way I can really answer you, Ricardo.
That's right. That's good. The second question is the indication. I talked to Wykovic from Berlin some years ago, and we have tried to do in Curitiba the indication for a patient with dementia for cerebrovascular occlusion. Do you have any experience with this indication?
Yes, I know what you are referring to. Vascosi has a very nice paper that has shown increase in brain volume after bypass. I don't have a well-documented case like that. I forgot what year he published that paper. But I can tell you, I have not done bypass surgery for non-TIA or non-stroke patients. I have not gone there. But in those patients, not only do they have TIAs and stroke, but as you know, many of them are CEO or executives of companies. They all tell you pre-op, their brain is in a fog. They cannot think clearly. You do the bypass, and their whatever you want to call it, their IQ improves with the bypass, their alertness, their ability to function. I have seen that numerous times. But I have not done bypass surgery just for cognitive decline without TIA or without a stroke. So I cannot really answer your question completely.
Thank you. Thank you. I don't know if other people have some question for you. Perhaps Andrea?
Okay, Professor, let's...
If not, we could continue with aneurysm, bypass for aneurysm.
Well, tell me how many minutes you want me to speak, and I'll tailor it to that.
Professor, you can speak as much as you want, because Dr. Sheikha, I think he's still in surgery. So we still have lots of time.
Okay. You know what? If you feel I should stop at some point, just give me a 1 to 2 minute.
You can go on, Professor.
Okay.
You can go on. The time is yours.
Okay. Thank you. Let's talk about bypass for aneurysms. So here is the message that I want the young people and perhaps not so young people to end up with. Bypass techniques, as you are still an option for many aneurysms, and very rarely, I have to confess, very rarely, some complex skull-based tumors. But it's the only treatment for many aneurysms today, in spite of flow diversion and many other endovascular techniques that are being abused today. This is my message. And the rest of my talk is to go over some principles and some case examples. I wrote a long time ago in this very nice book edited by Pascal Jabour, a chapter on reviewing microsurgical instrumentation in cerebrovascular. And, you know, I go over the details of how you sit down, how you use a mouthpiece for a microscope, how to understand the basic instruments, ergonomics, what are needle holders, what are forceps, what are basics physics, how you hold them, why do you hold them in a certain way? All those things, I guess we don't really teach enough in our residency programs, but they're very, very important. Here is a typical example, the difference between holding a forceps and holding a needle holder, and what are the forces and what is so-called mechanical advantage. It's a simple ratio of a lever. I'm going to skip some of that. These are the sutures we use. You can invent any bypass you would like today and give it to me, and I promise you I can fit it in one of these 5 types of bypasses. There are only 5 types. When you look at the number of anastomoses, whether it's more than 1 or less than 1, I'm sorry, 1 or more than 1, and whether it's, what is the type of the donor? Is it intracranial donor? Is it local extracranial? Or is it a distant extracranial? You see the 5 cells that you can fill. You cannot fill that cell on the left bottom because you cannot do a distant extracranial donor with 1 anastomosis. That's why there are 5, not 6 types. So let's go over some examples from each type. So no graft or graft, and local extracranial, in situ. And when you use a graft, is it short graft, intracranial, short graft, extracranial, or long graft? Examples. Let's start with this, simplest. No graft, local extracranial donor, either anterior circulation or posterior circulation. I'm going to start with an example of a double barrel. I'm going to skip. We'll make it visual. I don't want to show you too much text. I'm going to bore you. I'm just going to make it visual. Here is an aneurysm in a sickle cell patient. You can see the MCA aneurysm. You can see the STA. You may look at an angiogram like this and say, oh my goodness, the STA is so small, I cannot use it. I am telling you from case after case after case, never be discouraged by an STA that looks small on an angiogram. When you dissect it, it will open up, and many times you have much better flow than you think. Here is the aneurysm. It is fusiform, and there are 2 branches coming out from it. So you cannot clip it. You cannot endovascularly treat it because of its morphology. All you can do is a double barrel bypass to the 2 branches and surgical trapping of the aneurysm. We did an Allen test on the patient. Unfortunately, she failed it, so I cannot use her radial artery. So I could use her saphenous vein if I have to. But so here is the dissection of both STAs. You remember those STAs? They looked so small on the angiogram. Look how good they look at surgery. So here is the aneurysm you can see in the bottom right. And here is the 2 branches of the STA. I'm going to do end-to-end in one case and end-to-side in the other branch. And then when I finish, you can see bottom right is the final view with the trapping of the aneurysm. And that patient did beautifully. And here she is post-op CTA. And here is a post-op angiogram with the bypasses patent and the aneurysm occluded. You can see the patent bypass here. An example of the posterior circulation, occipital artery. I showed you an occipital artery example earlier for ischemia. There is an example for a pica fusiform aneurysm. You can see double origin of pica, a fusiform aneurysm of the pica common trunk that was enlarging over time. I took the occipital artery and I did the bypass. I'm not going to show you that video, But I am going to show you a video of an occipital artery to PCA, P4 bypass, nicely edited by my previous fellow, Georgios Zenonos, who's now in Pittsburgh. We did this case together when he was my fellow. Again, I don't want to show you text. Here is a case that was coiled elsewhere and recanalized. You see the recanalization? And so I recommended bypass for this case. You have to bypass the PCA. And of course, the occipital. Oh, by the way, there is a stent coiled. You see the stent here? So it makes it harder because you cannot bypass the stented segment. So I can bypass the parieto-occipital artery. It means I have to go interhemispheric. I like to use a lumbar drain in these cases. You can see the position. And here we are dissecting the occipital artery and making the incision as I showed you. It's a hockey stick incision. Gravity allows the occipital lobe to fall away. You can see there is no self-retaining retractor. You have to cross the midline with the bone flap and apply traction on the dura. And I am identifying, actually I used intra-op navigation also to identify the parieto-occipital artery. There it is. Of course, you don't want to bypass to the calcarine artery by mistake. That'll be a disaster. You'll create homonymous hemianopsia and an occipital infarct. So here is the parieto-occipital artery. And we are going to bring in the occipital artery. I create enough of a recipient area. I measure the flow, as always, 58 cc per minute. And you need to make sure the occipital artery is long enough to go to the parieto-occipital artery. I measure the flow in it, 10 cc per minute. All I need is 10 cc per minute, and the occipital artery can give me 58 cc per minute. So I have plenty. So here we are. It's deep. It's not an easy bypass. It is deep, but you can see how much room I created. And you can see I really don't need a self-retaining retractor because I have a lumbar drain. And you have to clean and fish mouth the STA so your suture does not catch with the fascia. And you notice how I'm bringing the recipient artery closer to me. So I make it a little easier, and I'm using a disposable arteriotomy sickle knife to create the arteriotomy. And here we are doing the 12 o'clock position first with a 10-0 suture. And, all of these anastomoses are the same. And I'm using, in this case, a running technique to make it a little faster. This way I can tighten the loop after I put them all together. I call it the hand over hand technique. I learned this more than 25 years ago from Spetzler when I was his fellow, and it's a very good, efficient technique to suture, particularly at the depth like that. So you avoid having to tie the knot multiple times. And when the anastomosis is completed, you remove the clips. Now, what do you think the flow will be? The flow will be 10 cc, not 58, 10 cc antigrade, because it is not needed. There is still antigrade flow. So then the next day, we took the patient, of course, to occlude the PCA endovascularly. And you can see here the nice patent bypass after occluding the PCA endovascularly. And here is the patent bypass on CTA, and the patient did excellent. There is an ischemia deep, but not causing hemianopsia. This is the branch, due to the branch of the parieto-occipital that I took in order to mobilize it. Let's go over the next type of example, in situ bypass. In situ bypass, is when you don't use an STA, you use intracranial to intracranial in situ. This is such an example. You might look at this MCA aneurysm, you might say, oh, but this is clippable. I couldn't clip it. It was heavily calcified. So what did I do? I excised the entire segment and I did an end-to-end anastomosis, as you can see in the post-op angio. That's the simplest, most elegant example of in situ bypass. Another example of in situ bypass is using the anterior temporal artery. Here is such an example in a 79-year-old woman who had a warning leak, not a full-blown subarachnoid hemorrhage, but a warning leak. Here is her partially thrombosed MCA aneurysm. Unfortunately, she had had a facelift. She does not have an STA to use. So here is her aneurysm, very complex. Even today, there isn't a good endovascular option for this. How did I do it? I'm not going to show you the whole video, but I used the anterior temporal artery as a donor. You can see these arteries are completely stuck on the aneurysm. So here is the anterior temporal artery. You can see it is nice and mobilizable. Here it is. I cut the anterior temporal artery and I am going to do an end-to-side anastomosis. I'm going to go to the end of the video. After doing this anastomosis, I proceeded to transect the neck of the aneurysm. I'm using the CUSA to take the thrombus out from inside the aneurysm. And now I transected it completely and I can clip the neck of the aneurysm. And of course, I always measure flow after clipping to make sure everything is good. So post-op, you can see what my bypass did. It allowed me to take care of the outflow and completely obliterate the aneurysm. It's a very good example of in situ bypass for an MCA, complex MCA aneurysm. You can use in situ bypasses for A3 to A3 bypasses as well. I skipped that example. Another example of MCA like this, very complex base, not treated easily endovascularly. In this case, we're going to do M2 to M2 bypass. You see in this bottom right picture, the temporal M2 and the frontal M2 are side by side. So all I need to do is do a side-to-side anastomosis between them. This way I can sacrifice one of them in my clipping of the aneurysm. So that's what I did because the base of the aneurysm is complicated. Here is the side-to-side bypass completed. All the numbers indicate the flow in cc per minute in each segment. And here now I attack the aneurysm and I do picket fence technique. You can see the calcified base of the aneurysm. I could not advance the clips any deeper because I would lose the perforators of the MCA. You can see a small residual aneurysm. I knew I was leaving, but interestingly, in 10 years, this aneurysmal residual did not grow, and the patient did excellent. It's heavily calcified. Here's an example of A3 to A3 bypass in a traumatic aneurysm. And you can see this aneurysm 17 years after a head injury. She developed this traumatic aneurysm at the edge of the falx. And here is an interhemispheric approach and side-to-side anastomosis. And that is a post-op CT. You can see the clips in the bottom right picture where they are trapping the aneurysm, and the bypass on CTA is patent. How about posterior circulation? Many examples of in situ bypass, particularly with pica aneurysms. Here is an example of partially thrombosed pica aneurysm with a TIA, presenting with a TIA in a 78-year-old patient. Here is her aneurysm. I could not clip it. It was heavily calcified. So I excised it and did an end-to-end anastomosis. Here is another pica aneurysm, subarachnoid hemorrhage. You might look at this aneurysm and you might say, oh, that's very easy to clip. And I thought so going in. I did a far lateral approach. That's how I like to position the far lateral. Expose the aneurysm. Look at this aneurysm, top left image. It's not as simple as the angiogram suggested. Why? Because it's 270-degree circumference involvement. So I tried clipping it, and every time I would clip it, I would leave a segment untreated. So I excised the segment, as you can see in the bottom right, and did an end-to-end anastomosis. That was the best way to deal with this unclippable or only partially clippable aneurysm. I'll show you, I'm going to skip this video because I have lots of videos. Another example of subarachnoid hemorrhage from a pica. Look at this aneurysm. You tell me if there is an endovascular method today that can treat this aneurysm. There isn't. It's a distal pica fusiform aneurysm, unless you sacrifice the pica, which may end up with a major brainstem pica infarct, Wallenberg syndrome. You don't know if the patient will tolerate sacrificing the pica. So what did I do in this case? You can see this complicated aneurysm on 3D. It's essentially a laminectomy because this is very low in the cervical spine. Here is one origin of the pica. You can see it, tip of my sucker. Here is a second origin at the level of C1. You can see the blood clot, the spinal cord. I'm measuring flow. And here is the aneurysm buried in the clot. So oh, by the way, look at the perforators coming off the pica, going into the spinal cord. Can you imagine sacrificing this segment? I mean, you'll make the patient probably quadriplegic. So obviously not a good option. So I excise the aneurysm. You can see the double origin of pica here and here, and then end-to-end anastomosis. And here is the final view. Very, very good solution and a cure of this complex aneurysm with subarachnoid hemorrhage. There is no other method. I'll show you another case of a pica to pica bypass. In this complicated pica origin aneurysm, you can see this one lobe of the aneurysm. But look, there is another lobe. As I rotate, you see the other lobe? It is here. So it's two lobes, one large, one small. You cannot clip this aneurysm. It's two separate lobes. You cannot clip it completely. You can clip it partially. I don't want partial treatment. There is a large pica. So I'm doing a far lateral approach. And I am going to skip all that. And I'm going to just take you to the view at surgery with the video. Number one, look at the fantastic view of the aneurysm with a good far lateral approach that crosses the midline. And I'm crossing the midline because I need to do a pica to pica bypass. There is a view. Isn't this a fantastic view from the far lateral approach? And here is the pica to pica getting ready to do the anastomosis. Here is the almost completed anastomosis. It will end up looking like the letter H. And then I trap the aneurysm completely between 3 clips. Here is me at first, of course, trying to clip it, but I couldn't clip it before the bypass. And the bypass, maybe I can show you parts of the anastomosis. Always do the 12 o'clock position first. You, with a curved needle holder, you put the suture behind the knot and you run it. You run the back wall of the bypass. And because I'm right-handed, I will do out, in on the left side, then in, out on the right, out, in on the left, in, out on the right. That's how you run it. For a left-handed surgeon, you do the opposite. You can see me running here with the suture, leaving the loops loose. Then I tighten them, I make the knot, and I do the simpler anterior wall. That's how I do it, at least. I run the anterior wall. The bypass is completed. You make sure it's patent before you trap the aneurysm. A tiny bit of leakage at the 6 o'clock. It doesn't need a suture. All it needs a little pressure and it will stop. And we proceed to trap the aneurysm, and I don't need to show you that. Here is a post-op angiogram. You can see the H-shaped bypass right here and the trapped aneurysm. You can see the bypass that's patent between the two picas. That's a classic pica to pica bypass, and here she is doing perfect post-op, went home within 2 or 3 days. I'm going to skip this pica aneurysm because I managed to clip it. Let's go over graft examples. So how do you deal with this complicated P2, P3 fusiform partially thrombosed aneurysm? There isn't a good way to do a flow diverter in these. Look at this. It has a very irregular channel. So I did radial artery from PCA to MCA, going around the temporal lobe. You can see the view, you can see the post-op angiogram, and then endovascularly sacrifice the PCA. So this is a nice combination of microsurgery complemented by endovascular the next day. And here she is, 1 year post-op, excellent patent bypass. I don't really have time to show you it's a nice video that shows the techniques of PCA bypass. I am going to go to another example of failed pipeline. Here is I'll show you quickly part of this video. This is a patient with dolichoectatic vertebrobasilar treated with 2 telescoping stents, and the patient kept getting worse and getting brainstem compression. So I did an ECA to PCA bypass with radial artery interposition. After occluding 1 vertebral artery with coils, you can see that right there on your left, under the pica. Then I did the bypass. So this is a subtemporal approach to expose the PCA in the ambient cistern. Here is the PCA. In these cases, I put 2 self-retaining retractors because this is deep and you need room to be able to do the anastomosis. Here is the radial artery, and here is the end-to-side anastomosis. This is a suction device to help with keeping the field clean and the suturing. And in this case, I did interrupted because it was quite deep and I did not want to have, in this specific case, to rely on a running suture in case I tear it. So after finishing the anastomosis, I tunnel with a chest tube, 28 French chest tube in front of the ear in the preauricular area, down to the neck. And here is the external carotid, end to side. Here I use an aortic punch to take a piece of the wall because it's very thick from the external carotid. And I am doing an end to side anastomosis. Here I think I'm using a running technique. Yes, I used a running technique. Here is, of course, it's much easier. When the anastomosis is finished, I measure the flow. You can see the bypass subtemporal, and then, as I said, the next day, endovascular occlusion. Of the vertebral artery. I think this is my last example of a complicated MCA aneurysm. And please, you tell me if there is an endovascular way to treat this. There isn't today. Maybe someday there will be. But today you have 1 inflow in green, the M1, and 3 separate outflows in red. How are we going to handle this aneurysm? You have to do a complicated triple bypass, and that's what I did on this case. I had the STAs exposed, but they were too small. So I used a radial, this is a complicated bypass. I used the radial artery, but 4 anastomoses, but please notice the numbers. The numbers is the order in which I did the anastomosis, and it's very important. First, I put the radial artery in one of the outflow. That's anastomosis number 1, end to side. Then I went to the neck of the patient and I did the second anastomosis in the neck to the external carotid. So flow is now running into this bypass. Then the third anastomosis is side to side between the radial artery and the second outflow. And lastly, the fourth anastomosis is a reimplantation of the third outflow into the second outflow. I know it's complicated, but it is a complicated disease that I had to think a lot about how to handle it. I don't really have time to show you the video, but maybe just to show you what the aneurysm looks like. You see, here is the aneurysm. You see, there are 3 separate outflow. You can see them, 1, 2 in the middle, and the one on your left. And I'm measuring flow and then doing the radial artery bypass. In the sequence I told you, I usually use 8-0 when I'm using radial artery. Here is one of the anastomosis in the neck, in the external carotid, coming back to the head to do the third one. And the last one, which is where my mistake was. I made a mistake here. I chose an atherosclerotic or thickened part of the third outflow. And this fourth anastomosis occluded later and caused an infarct. You see the thick wall? I should have chosen a healthier part of this artery to reimplant it. I don't think I would have had the complication. But here is that. This anastomosis I'm showing you now is the one that was patent intra-op, but occluded later and caused the patient to be in the hospital for a long time. But this is a final result here. You can see it. And here is the angiogram. Everything was patent at first, but occluded later. I'll show you. Here is the conceptual thinking of in what order to do the anastomoses. And what I did is this one, the triple reimplant, what I call the triple reimplantation, what I just showed you. Here is the infarct due to the occlusion of the fourth anastomosis. The patient had a rough post-op course, but here is the infarct. But look at her 1 year later, completely recovered. Arms, hands, everything working, aneurysm completely gone. So conclusion, I tell my resident, I have 10 commandments of bypass surgery for tumors and aneurysm. You can read them, particularly in red. Select the patient properly. Choose the simplest way to do it. You have to be surgically proficient. You have to practice in the lab. You have to understand the forest and the tree, details and overall view. You have to be absolutely meticulous, attention to detail. Heparinize irrigation. Do not accept clot formation. Quantify flow. I don't like to stage aneurysm treatment unless I have to. I've shown you some examples of staging, but whenever possible, I like to do the bypass and trap at the same time. If I cannot trap because of perforators, I reverse the flow, or I can do distal occlusion. There are many other ways I haven't shown you. You have to teach the young people, young neurosurgeons, to know how to do this, because as you can see, in spite of endovascular, you still need to know how to do this. And last but not least, always think outside the box, be creative, adaptable, and versatile. So those are the 4 commandments. And please don't take my presentation as a critique of endovascular. As I've shown you, the two can coexist and should coexist and be complementary with each other, like tradition and progress can coexist together. And thank you very much. I will stop sharing my slides and happy to answer any questions you have.
Perfect, Professor. Thank you very much for your presentation. It's completely awesome. I wanna ask Dr. Paulo and Dr. Ramina to start the discussion. Dr. Ramina.
We start more with vascular lesions in humeral surgery, and we'll have some bypasses.
Hi. I have a doubt in posterior circulation, fusiform aneurysms. Do you think that the bypass is superior statistically than endovascular procedures as flow divert?
No, yeah, Paulo, very good question. I cannot generalize that. I can tell you that some vertebral artery aneurysm, much better to do flow diverter. The problem is prediction of flow through the pica. Some dissecting aneurysms distal to pica are better done endovascularly. The dolichoectatic vertebrobasilar is a terrible disease, both endovascularly and microsurgically. We don't do well. I showed you an example that did well. I have many others that did not do well. Some PCA aneurysms that are fusiform certainly can be done with flow diverter. We need better endovascular technique to solve the dolichoectatic vertebrobasilar. It's not solved yet.
Yeah, interesting. You in P2P fusiform aneurysm, you have done P1 to basilar or posterior cerebral artery bypass to exclude P2P. You have a short bypass, but you have a narrow field to do. Have you done before?
I have, but not to the basilar. I've done it. I've always chosen the safest way, to be honest. And usually the STA is there. I mean, unless it's not there, why not use STA to PCA bypass? When you use flow measurements like I do, it gives you the assurance that you're putting enough flow. The technique, again, that Fadi Sherbel has described makes, and he and I always think alike in this way, measure how much flow you need, measure the flow in the STA. If the STA has equal or more flow, use the STA. It's so safe as opposed to doing a deep intracranial to intracranial, more dangerous bypass. That's been my philosophy. If there is no STA, then I take it up a notch, and I will do, as I showed, an MCA to PCA bypass, like create a long PCOM, pretty much.
Do you consider that, for instance, in the Moya disease, to do STA to middle cerebral artery or encephalodural mucinangiosis is because we have done a lot of Moya with encephalodural mucinangiosis and not
without a direct. You mean just with indirect, with EDAS?
Yes.
In adults,
not in the critical case, only in cases with critical status. But in critical status, we use STA. But STA normally in Moya doesn't work. I don't know your experience for that.
No, I mean, that's what I described earlier. It works very well. Out of my 162 cases, 161 were immediately patent with STA MCA bypass.
But in our cases, in not critical and critical use.
I use it, I never use indirect in adults unless I've used it once because I couldn't get, the recipient artery was too small. In adults, I'm not talking children, I'm talking adults. And yeah, absolutely. Peter Vascosi, I have a whole other lecture showing you what the literature says about meta-analysis of indirect versus direct. Vascosi himself has shown how much better flow you get when you do direct compared to indirect in adults. There is really no reason, I mean, to be honest, unless there is no expertise to do direct anastomosis, there is no reason to do indirect in adults. I've operated on failed indirect too many times, done at my institution by some other, people who don't know how to do direct and whose patients stroked after indirect bypass. And then I had to go and salvage and come up with, try to save the STA and do direct. I strongly encourage, particularly young people who still have time to train, to master direct STA-MCA bypass. It will save them in so many ways.
Yes, because we have two groups of moya. The patients stable with few episodes or crises of ischemia, few epilepsy attacks is the group one, and other group is the patients with ischemic status, very bad, a lot of headache. This group, if I use direct or indirect, the results could be also not expected. But the first group, I think that I am not so aggressive. But in the second group, I try always direct attack.
The problem, Paulo, as you know, 50% of moya patients will progress clinically within 5 years.
Yeah.
And if you do indirect, you cut away your possibility of doing a direct bypass in the future if they need it. So my philosophy is I want to give them as much maximum blood flow as I can in one operation, so I don't have to ever operate on them again. That's my principle, That's
okay.
Very good presentation, Jack. Very nice case, very difficult case. I'd like to ask you a technical problem. How do you handle the radial artery graft? Do you remove by yourself, or the heart surgeon remove for you and uses some solution to avoid vasospasms?
Yes, I don't remove it myself because it's nice to work in parallel. I have two groups of surgeons who could take it. My actually head and neck surgeons with whom I'm sure you work with in your skull-based practice with head and neck surgeons who do free flaps. They're great, and I work with them all the time. So they sometimes remove the radial artery, or the peripheral vascular or cardiac surgeon, depending which team is available. We soak it in a solution of a calcium channel blocker and heparin. And I still use, not to the extent shaker, you should ask him the same question when he talks after me, the pressure distension technique that he described many years ago, up to 180 millimeter mercury. I don't really use it as much, but I make sure absolutely I clear away all the fascial bands because they create stenosis. That's what I do.
Okay, thank you very much.
I think I've spoken enough today. No, we should probably.
It was very good, very, very good. Thank you very much.
Thank you, my friend, to all of you, my friends, for inviting me and for allowing me to share whatever I have with our Brazilian colleagues. And please stay safe. Paulo, feel better, my friend, and I'd love to.
Thank you very much.
All of you in person one day.
Thank you very much, Professor.
Bye, guys.
See you again. See you again.
Thank you.
Bye-bye. E agora vamos na aula do Dr. Sheika, porém ele ainda está em cirurgia. A gente pode esperar mais uma meia hora e aí retornar. E uma outra ideia que eu dou seria a gente encerrar por hoje e aí eu reprogramo com o Dr. Sheika para sexta-feira que vem às 7 horas. O que vocês preferem?
Eu acho, André, que é difícil porque é muito difícil saber que horas termina a cirurgia.
Exato,
Então, acho que é
exato,
mais lógico a gente reprogramar mesmo.
Eu acho que ele já terminou, André. Você não quer esperar um pouquinho?
Eu estou mandando mensagem aqui para ele, doutor, e ele falou que ia entrar em cirurgia e que ia sair mais tarde. Só que não me falou a hora. Eu também não quero ficar pressionando ele.
Não, tá bom. Depois você me liga.
Ligo sim.
Bom, tá bom. É porque eu tenho outra informação, né? Mas não tem problema. Dele, né? Então, ele está escrevendo isso. Vamos esperar, então, uma outra data para ele. Então, o que você acha?
Eu já marco semana que vem, se vocês dois autorizarem, porque eu acho que até fica mais cômodo para ele e para todo mundo que está aqui, para não ficar esperando até uma hora aqui.
Que a aula dele é muito importante. O que você acha, Ricardo?
Eu acho, vamos remarcar, porque eu acho que a gente tem que ter tempo para discutir, para escutar com
Claro.
Então, acho que
assim, a aula dele vai acontecer, isso é fato, né? Eu acho que talvez se a gente deixasse para sexta-feira que vem, vai estar todo mundo também um pouco mais descansado. Eu peço desculpas até por ter marcado 2 professores de fora. Muito difícil,
ótimo, André.
É muito difícil. Porque é muito difícil linkar. Se vocês perceberem, todos os outros módulos nós temos só um palestrante externo e todos do Brasil.
Não, mas foi ótimo, André. Foi excelente. Eu acho que, pelo contrário, quanto mais de fora, isso é uma raridade que aconteceu com o Shekhar, viu? Mas é excelente. Eu acho que um dos atrativos de hoje foi ter 2 exímios cirurgiões de fora, com os comentários do Ricardo Ramina, que atraiu o público para assistir. Acho muito bacana, pelo amor de Deus. Põe bastante gente que atrai, como esses 2.
Então, vocês concordam? Então, Ramina, vamos encerrar então.
Tá. Concordo. E a ideia desse curso realmente é a gente ter espaço para poder escutar, discutir, ter tempo. Então, não sem pressa. Perfeito.
E até é bom a gente aprender com esse, digamos, esse ano para o ano que vem a gente fazer um negócio mais, quem sabe, com mais tempo para mais perguntas e mais discussão, que eu acho que é o que interessa mais, né? É importante ver vocês falando e a gente aprende junto com essa discussão. Então, a gente encerra hoje e eu passo para todo mundo por WhatsApp o horário da próxima aula na próxima semana com o Dr. Shekhar. Ok?
Obrigado.
Tá ótimo.
Muito obrigado.
Era isso que eu ia pedir para você na ligação, que está muito ruim meu celular. Eu não estou, às vezes, ouvindo vocês. Por isso que eu ia pedir para o Shekhar voltar semana que vem. Então, vocês estão conseguindo me ouvir?
Sim.
Tá, que está muito ruim. Tá? Obrigado.
Tá bom, doutor. Obrigado, doutor Ramina. Obrigado a todos. Então, até semana que vem.
Tchau, obrigado.
Tchau.